Watch me map out my entire face for a full face neurotoxin treatment. It has been 4 months since my last treatment, and I practice what I preach. I wait until my full movement is back. I'm not doing little touch up doses in between. I have my full frontalis movement, my glabella, my 11s are starting to show, and it's been 4 months. So it's appropriate for me to treat now. And I wanted to show you guys how I map my entire face. Now, I tell every one of my patients, don't come back until their full movement has returned or at least 3 to 4 months. This takes care of your patient. This minimizes the risk of possible resistance and it prevents an asymmetrical result because if you're layering tox with new tox, then you're going to have this asymmetrical result. And I tell them every time an injector can only treat what they're seeing. So if they have a frozen forehead and a moving glabella, you're going to appropriately treat the glabella, but you're going to lightly treat the frontalis, and then the frontalis full movement is going to return, and they're going to feel like you watered down the tox, and that's not the case. So educate your patient on don't return until you have full movement or 3 to 4 months to make sure that you get a beautiful result every single time and minimize the risk of resistance. So I'm going to map out my face in particular. Now it's important that we look at every patient's unique anatomy. What works for me isn't going to work for Susie, isn't going to work for Jessica. You have to look at your patient's particular anatomy to determine what's best for them. But I'm going to show you little tips and tricks on my own face that I love and things that I learned along the way that you have to keep a lookout for. But hopefully you can take some tips and tricks and kind of reapply them to your own patient. So let's map out my entire face. So we're gonna get really up close and personal because I really want you guys to see my muscle movement. And this lighting is really weird because this lip gloss is actually pretty brown and it looks really red. I have a mirror down below so I can look at my muscle movement. I'm going to put my hair back so you guys can see everything, but I'm going to take you step by step on exactly how I map out my face. Now, again, this is for my face. It's important to look at every patient's unique anatomy to determine what is best for them. So this pattern of injection is not going to work for your patient, but my goal is that you get little tips and tricks and you can see my thought process on how I look at a face for a full face neurotoxin treatment. So I'm going to use a different color for every muscle and map it out exactly how I would perform my neurotoxin treatment. So I have a mirror here and I'm going to look. Now I'm going to start with the corrugators. The glabella is combined with the procerus and the two diagonal muscles of the corrugators. And these muscles work together to bring your brows inward and downward. So, which is what's creating those 11s. Some patients have a 111 and some patients have a 1. So it's important to look at their particular anatomy. But for me, I have a pretty classic textbook 11. You could see my two faint shadows right there. So for me, I use about 20 to 25 units of neurotoxin. But again, it's all about learning your particular neurotoxin. Don't worry about what Betty's using down the street. Get experience with your neurotoxin, get comfortable with its spread, get comfortable with its dosing, get comfortable with how it performs in different types of tissue. I work part-time in the villages, so my average patient, which is a retirement community, my average patient is 60, 70, 80. I even have 90-year-olds. Then I have in Claremont my young professional mom, young professional dad, the younger demographic. So I need to know how my neurotoxins perform in every single type of patient. So it's all about just getting comfortable with your neurotoxin, your dosing, and how it performs. So don't worry about anybody else. But this is how I would move my face. So in the glabella, I'm going to inject, let's see if this, oh, that marker is kind of, can you see that? We're going to down from over here. Let's see if this blue one works. Oh, that's going to be good. Okay. So neurotoxin in the procerus, I'm going to start out right there with the procerus. Pretty classic textbook. My glabella doesn't need like a 3-point injection on each side. My glabella is pretty textbook, but remember these corrugators and the procerus, they draw those brows inward and downward. So you can see my muscle movement. You can see when I make that 11, or I bring my brows together, you can see I am pulling from the tail. So if I get really close right here, so relaxed and then bring it down, you could see the tail of my corrugator is right here. So you don't want to go lateral to that because then you're going to be hitting the frontalis and that's when you're going to weigh down the brows, which we'll get to. So for me, you want to keep those two pokes concentrated to the movement of the corrugator. So I can even mark out the tail of my corrugators. So you can see I don't want to go lateral to that. I want to stay right there, medial to the tail of my corrugators. Now, the medial part of the corrugator is thicker. So you have to insert your needle deeper to get the belly of the muscle. The lateral tail of the corrugator is thinner. So you only need to go superficially to get the belly of the muscle there. So medial corrugator, deeper, lateral corrugator, more superficial. So for me, I would simply do my markings just like that. Pretty classic textbook. That's what every neurotoxin recommends for their 5-point injection technique, and I'm pretty classic there, so I wouldn't spice it up there. But that's how I would mark out my glabella. So now working on the frontalis. The frontalis muscle is the only eyebrow elevator that we have. Now there's also something that Sebastian Codafana, which is an incredible anatomist, published about the line of convergence, which is a horizontal line where the frontalis kind of has opposing functions. The upper part is thought to drop down the brows and put weight or bring down the frontalis or the scalp. The lower part is an elevator. So if you inject below the line of convergence, then you're going to get some heaviness in those brows. For me, I don't necessarily on a day-to-day basis think about the line of convergence. For me, I just understand that the closer I get to those brows, the heavier they're going to be. So depending on your patient, depending on their movement pattern, you'll have to look at it on a case-by-case basis to see what's going on with their particular anatomy. For me, again, we're injecting me today. So how I map out my frontalis. Now, I am very sensitive to keeping my brow arched. I love an exaggerated arched brow. I feel like it's really feminine and pretty. I love that look. So for me, I rather have a little bit of movement and a nice arched brow than a frozen forehead and a heavy brow. That's just my preference. Some patients love a strong forehead, a strongly frozen forehead. For me, I'm okay with a little bit of movement. So the way I map out my forehead is one, you always have to remember, is that patient moving past the temporal fusion line, which is that line right here above the tail of the brow where that frontalis and temporalis meet. If they're moving beyond that, more lateral to that, then you have to take that into consideration because the more lateral you get, the more heavy of a brow you get. So you really have to fine tune your dosing. Maybe put a half unit lateral to that temporal fusion line. So here's how I map out my forehead. So let's see if you guys can get a good view. So for me, I go right above the tail of the brow. So right there, I'm going to put about a unit there. Nothing crazy, but obviously I don't want to spock. So if I don't put that unit right there, then I'm going to have aggressive movement and it's just going to look really unnatural. Then I'm going to start creating my pattern. Now, if you see right here, I have a little righted pretty close to the brow. I'm not going to try to tackle that completely. I'm going to go right here and I'm just going to keep working my way. Now, if you look at my forehead, if I do not inject the central part of my forehead right here, you can see how I would experience this like bulge effect. So I have to make sure, and I learned that the hard way. I'm looking at my screen, so forgive me. I learned the hard way that if I don't put a poke right there, then I'm going to have this like bulge. I call it my boner frontalis, where it just kind of like puckers right there. So I need to put a dot right there in the middle to help prevent that. And I'm going to tell you something that I do specifically for me and certain patients, and then it lands right there above the tail of that brow, above the arch of the brow right there. I don't have a lot of movement outside of the lateral to the temporal fusion line, so I'm not really worried about going that far. One thing on me, and what I always pay attention to because it bothers me, is I have movement in my hairline. If I do not tox my hairline, then I will be frozen and then have this one little wrinkle in my hairline. So always take a look at your patient's hairline to see if they have movement. So I will always go 1, 2, 3. Now, typically my dose for the Frontalis is about 12 to 14 units. The older I'm getting, the lighter my dose is getting because my Frontalis is weakening and it really can't tolerate. So understand your patient's anatomy. One thing I always like to tell my brand new patients is always give me one treatment to really master your dose. This is kind of my spiel, I'm going to inject you based on my experience and what I think is best for you, but you can respond differently than what we anticipated. So I always say, be patient with me for one treatment so I can really understand how you respond. And then after that, we'll master and perfect your dose. And it gives you that little like leeway with your patients that if you quote unquote mess up or they respond different than what you anticipated, then they're not feeling like you're a horrible injector. They're like, well, she did say that she needed one treatment, so let me go back and show her what's going on. It's a relationship, and I tell them that. I say, I'm not perfect, I'm human, I'm going to do the absolute best for you, but your Frontalis may want something different. So I always undertreat, and I'm always conservative that first treatment, and then I always say, we'll build upon that and perfect your dose. But I tell them, always give me one treatment to not think that I failed you. Every patient is completely different, and how they respond is completely different. So that's my Frontalis dosing. Let's move on to the crow's feet. Okay, so for the crow's feet, we know we have the sphincteric orbicularis oculi muscle. So you want to make sure that you're not going too medial to that orbital rim, or it's going to track inwards, and you're not going too lateral because you're not going to get the right its. I never mark out the crow's feet for my patients. I mark out everything else before I inject, but the crow's feet, I kind of just follow their lines. The tail of the brow, remember this part of the orbicularis oculi is going to draw that eye inward and downward. So when you inject a little neurotoxin in the tail of the brow, it relaxes that function and you get this brow lift. It's honestly my favorite poke of the entire treatment is a brow lift for my patients. It's the one thing that really stands out for patients. They come and they're like, oh my God, please don't forget the brow lift. And I'm like, girl, I would never forget your brow lift. Every patient, unless they have some wild anatomy where they're super naturally kind of aggressively arched, every patient needs a brow lift. For my females, my males don't get a brow lift. But I always inject, where's my mirror? I always inject the tail of the brow, and for my brows specifically, again, I like an arched brow, kind of aggressive with the units. I'm doing 5, 6 units there. Usually it's 2 to 4. I typically maybe 7 if I'm feeling frisky, but I like a good raise. I'm going right underneath the hairline, about 3 pokes. Can you see that? 3 pokes in the tail of the brow. And then I'm going to follow my crow's feet. Now I'm going to go poke, 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 and one superficially right here. Now, if I'm feeling frisky, sometimes I'll go into the medial because you can see that I pinch right in there. You see that? How I pinch there? I'll go right into the medial canthus and do one little poke right in there, and then I'll repeat on the other side. So, poke, 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 and then one superficially. So those are my crow's feet. I'm typically doing 2 units per spot. So maybe I'll do 12 to 14 units. Again, every dosing is different with your patient, so look at your patient's anatomy. But those are my crow's feet. You can see I just follow the lines. I don't really mark them out. And when you have those patients with heavy lateral cheek crow's feet, you have to do some educating for them. You have to explain to them, if I were to completely freeze your crow's feet and you have all this movement in your lateral cheek, whether it's relaxity or the muscle being really strong, the zygomaticus muscle, you have to educate your patient on the fact if I freeze this, you're going to have, whenever you smile, this harsh ledge. And we've seen it. I've done it to a patient. I actually have a whole complications lecture on how I explain this. But if you freeze them with a lot of movement in their lateral cheek, you're going to create this weird shelf appearance in their lateral cheek, and it's going to look really unnatural. So anybody who has harsh lines tracking into their lateral cheek, I always tell them, unfortunately, I don't think it's a good idea to completely freeze your crow's feet because I think it's going to create this unnatural ledge when you animate or express or smile. So I'd like to gently dose those crow's feet so that it kind of cohesively blends into that cheek versus frozen shelf. They'll thank you, and most of the times they'll say, oh my God, I've experienced that every time. Like, thank you for pointing that out. Those little details will separate you. So let's move on to the bunnies. So when I mark out my bunny lines, I don't have strong bunny lines at rest, but when my entire face is treated and at its peak, I definitely recruit my bunny lines. So it's one of those things that I explain to patients. You might not feel like you're super strongly bunnied, but when everything is frozen, you might recruit that because there's only one way your face can move and it's going to recruit the muscles that aren't paralyzed. So I always treat my bunnies, even though I don't feel like they're strong normally. But once my full treatment is in effect, you definitely will notice that your bunnies recruit and almost compensate. So for that, I always just go right on either side. So I have a strong righted there. God, what a horrible face. And I just put 2 to 3 units per poke, nothing crazy. I do not do a gummy smile tax because I don't have a gummy smile. But if I did, I would go right in here about, depending on the patient, if they have a strong gummy smile, I'm using 5 units per. Remember, that's the LLSAN, levator labii superioris aliquid nasi. LLSAN muscle. Levator labii superioris aliquid nasi. LLSAN, that's that muscle that draws all the way down. It's that lateral thin muscle on either side of the nose, and it helps elevate the upper lip. Now, if you have a hyperactive LLSAN, then it's going to create a gummy smile. So by paralyzing that LLSAN, you're going to drop that upper lip. So I will go, and this is not what I do for me, but I'll show you. I'll go right in the corner of the nose, about 2 to 5 units depending on the patient. I always tell them we're going to start with the least amount of units, and if you don't get a great result, then we'll increase from there. But I always like to see if they can get a great result with the minimum of units. So working our way down the face, we are going to now do the oral area. So when it comes to the orbicularis, or as I don't do a lip flip one, I hate the side effects of it. Some of my patients live for it. Personally, I don't like the side effects, so I always skip the lip flip or paralyzing the orbicularis oris muscle. But if I were to do it, I would go right at the vermilion border. Nice. Let me make these thicker for you. Right there at the vermilion border. About 2 units per poke. Depending on the patient. Sometimes if they have a smaller lip frame, then I only need 2 pokes per. Now, if I'm doing the mentalis muscle raises the chin and the lower lip. I love a mentalis muscle. Now, every mentalis kind of responds a little different, and I've learned the hard way. I have found that mentalis muscles are actually kind of tricky to inject in my experience. In my newer days, I definitely created the chin boner is what I call it. But for my particular mentalis, you could see how I pucker up in that mentalis. What I do for my mentalis is I go, remember, you want to stay medial to that DLI muscle. You hit that DLI muscle and they're not going to be able to draw that lower lip down. So their smile is going to look like this. Let's see. And they're not going to be able to draw the lip down because you paralyzed it. Remember that depressor labii inferioris draws that lip down. So if you paralyze it, it can't smile and it's going to be an elevated lower lip, or the other part of the lower lip drops down for your smile. lateral to that is your DAO, your depressor anguli oris. So for me, I do like to inject my DAO. For me personally, you can see my, yeah, you can see it right here. You can see my DAO right here. It's pulling. Watch again. That good. She's strong and she's getting stronger as I age. So I will do a superficial unit right here. And then I'm going to go all the way down. I follow the angle of my oral commissure and I inject a deeper unit right in there. So those, I'm doing 2 units each poke for the DAO. You want to make sure, again, you're not medial. So that's everybody's DAO injection is a little different. This I've found to be successful for me. I haven't hit a DLI, but in all the years that I inject, after 30 years of injection, I'm sure I'm going to hit one. I'm just waiting for the day. But this is how I kind of keep it safe. Pull the lip down in a frown. See where it's pulling down right there. Superficial injection, and then a deep one in that, what I consider the triangle of the DAO, just like that. So then I'm hitting the lateral border of that DAO. So that's how I kind of treat and look at my perioral area. So now moving on to the masseter muscle. For every masseter patient that I inject, I go through a full spiel, and I'm going to go through it with you today so that you kind of see my thought process. And I literally give this educational paragraph to every patient. So I say, if they're coming in for clenching, grinding, TMJ symptoms, or if they just want jawline slimming, the aesthetic side, I lay down the risks and the benefits of each one. So for masseter muscles, I tell them the medical pros of masseter talks are weakening that masseter muscle, improving clenching, grinding, headaches that come with it. It can have an incredible improvement in quality of life if you experience these symptoms. The aesthetic benefit is that you get this jawline slimming effect. Now, with the aesthetic benefit comes aesthetic risks. When you weaken that muscle, you are atrophying that muscle and thinning it down. Now, the skin that was draped over that hypertrophied or thickened muscle, when you weaken it, you don't just get rid of that skin. It's not that thickened muscle was helping anchor back skin. It was creating tension on that skin. So you get this appearance when it's thickened. When you weaken it, where's that skin going to go? Forward. It's going to move centrally. So what can happen is you worsen or create the appearance minimally of jowls. So I always tell my patients in your 20s, it's definitely less of a concern. But if you're coming to me in your 40s with TMJ symptoms and you want to treat your masseters with neurotoxin, I tell every single one of them, you have to understand the risks that come with treating your masseters aesthetically. We might worsen the appearance of the jowls. Now, if they want to treat after that, by all means, let's rock and roll. But you did your job at educating them on the pros and the cons of that treatment. I also explain the 2 side effects that can happen when injecting masseters. The masseter muscle is divided, let me close this marker. The masseter muscle is divided into a superficial belly and a deep belly. It's so hard to do. A superficial belly and a deep belly. You have to inject both bellies in order for one not to overcompensate. So I always say it's like a beautiful relationship. If you go down to bone and only inject the deep belly, the superficial belly is going to overcompensate and take on the weight of the weakened deep belly. So you want to make sure that you perform a retrograde injection all the way out to make sure that you hit both the deep and the superficial belly. If that happens, I always tell them this one's an easy fix. We just have to kind of re-inject and add more units. So, and then to calm down that superficial belly so that both were impacted. Now, on the other side, there's a side effect that happens that unfortunately it's a watch and wait, and there's not much we can do unless we treat the other side, which I don't usually recommend. This has happened once in my career and I felt so bad, but she was such a dear about this complication. So I tell them there's a muscle that lays right over top that masseter and it attaches to the corner of your mouth. That muscle is called the risorius and it opens up your smile. So it allows you to open up that smile. If by chance some neurotoxin bleeds into that muscle, we always like to stay low, but sometimes it can happen, then you won't be able to pull out your smile. Unfortunately, that's a watch and wait for me. I don't like to treat the other side, and I find that bizarre. So it usually lasts 2 to 3 weeks. It did on my patient, but again, she was a joy to, if there was any patient to have this complication on, it was her because she was wonderful about it. But I tell them that can happen. I always lay out the risk for the versus the benefits, because if it happens to them, they don't feel like they were blindsided, they were educated, and unfortunately it happened, and I'm sorry. So when I map out my masseter, I always clench down. You can see I'm moving. Clench down, and I do it purely for aesthetic benefits, but I know the risk of jowling. Likely when I hit mid 40s, I might stop, but we'll see. So when I inject the masseters, I like to mark out the anterior border of my masseter so that I don't go medial to that. I I have them clench multiple times, and I'm typically doing either a triangle of dots or a square. But I'm doing 20 to 25 units minimum. If a patient comes in and just wants 10, I'm usually saying no because it's a pretty girthy muscle. 10 might just disappear and they'll be underwhelmed. So I typically start 20, 25 depending on the patient, but I stay below the earlobe. I keep my markings, if you could see that, below the earlobe, because if you go higher to that, more superior to that, that's when you run the risk of injecting the risorius, and obviously we don't want that. So each side, again over here, God, this is hard. Clench, anterior border of that masseter, right there, and then 3-point injections or 4 depending on the patient. I go all the way down to bone and retrograde neurotoxin all the way back until I come out. So that's how I inject my masseters. And I always tell them it lasts about 6 months, so I do my masseters every other time. I'm not treating them every time. And lastly, the platysmal muscle. So the platysmal muscle is this thin sheet-like muscle that spans the entire neck, and it attaches on the jawline. And over time, you get this cumulative effect, this downward pull on the jawline, and it can contribute to that jawline laxity and making kind of a softer appearance in your jawline. So I am incredibly neck heavy. I express with my neck, I smile with my neck. My platysmal bands are very strong. Oftentimes I find that my girls that like to work out are constantly engaging that neck muscle, especially when they're squatting and bearing down. So my more gym girls have strong neck bands. For me, you can see I am incredibly strong in those neck bands. I'm doing about 10 to 12 units on each band. Now for these, I always explain, especially my quote unquote fit chicks, I always explain that they're going to feel weird during that first session because we're essentially weakening that neck muscle, right? So I told them that there's going to be a moment where they might be doing sit-ups or a plank where they're going to feel like their head is a little heavy. Some patients experience this, some don't, but I always like to prepare them so I don't get a call thinking that their head is falling off. So for my patients, I run them through that everything will be fine. And after their first treatment, it usually just becomes their normal treatment because I don't feel it at all anymore. But I definitely experienced that head weakness where I was like, Lord, this does feel heavy. So always explain that so that they're prepared. I like to focus my platysmal muscle and platysmal band injections more to the superior part where it attaches to that jawline because I want to get the most bang for my buck up here. I don't necessarily focus down here, but really you can see I have all 4 bands. Now some bands recruit their anterior bands, some recruit 3 and not 4. Always look at your patient's anatomy to determine which bands they're actually recruiting. So for me, it's all 4. So when I inject my patient's bands, I'm going to go right at the connection and about 2 centimeters apart. This is so awkward to talk and do it. I'm injecting those bands. I don't go past that because I don't find it beneficial at all. And sometimes you have to sit them in different positions because it's kind of a hard thing for patients to do that. I've noticed it's easy for me, but a lot of patients have a hard time kind of recruiting them in the moment. So I'll position their chin in different positions to help them. So again, this band, oh, right here, this band, it really helps. See, I can't recruit that guy anymore. No. Where is he? See? Now I jinxed myself. Where is he? Oh, he's right here. Okay. Right here. Oh, yeah. Okay. So for me, that's how I'm marking out my injections. Usually 2 centimeters apart, 2 units per poke, depending on the patient, depending how strong they are. But this result really cleans up their smile, their expression. We know our age shows in our neck. So I love doing platysmal bands for patients. Now you can even ride up and do a Nefertiti lift and superficially inject along their jawline. I don't usually do this on me, but it's a great option to have like this cohesive jawline neck treatment with neurotoxin. So for me, that's exactly how I would mark up my face. Again, I can't stress enough. What this looks like is not going to work on your patient, but hopefully you took some tips and tricks on exactly how I view the muscle movement, how I view the face, and how I avoid little complications and the little things that will help you stand out as an injector, like softly dosing the crow's feet instead of creating that harsh shelf-like appearance or looking in their hairline. Different tips and tricks to hopefully help you stand out as an injector. So I hope you took something from it. If you can, subscribe, help me out. I'm trying to get to 1,000 subscribers, so I hope you enjoyed that. If you have any comments, message me, comment below, whatever you need. I'm here for you. Would love to be a part of your journey.